Welcome everyone to our third in a series of 4 webinars highlighting infection prevention and pharmacy, the road to integrated stewardship during a pandemic. This hour, our webinar is entitled Maintaining Organizational Focus on Infection Prevention for CAUTI, a case study, which will be presented by Indiana University Health. Indiana University Health has targeted catheter-associated urinary tract infections, or CAUTIs, reduction as an area of focus in their organizational HAI initiative. With the resource constraints imposed by responding to the COVID-19 pandemic, the organization was faced with key decisions and prioritization of ongoing initiatives while managing the pandemic response. During this session, panelists will discuss the approach to ensuring appropriate prioritization, best practices identification and incorporation, and the importance of change management. Participants may submit questions via the chat box during the discussion. They will be addressed at the end of this session. The learning objectives today: number 1, how to identify and prioritize key initiatives. Number 2, best practices in creating protocol revisions and how to standardize compliance across several facilities. And 3, the importance of program design, cross-functional collaboration, and monitoring progress over time. Our presenters today are Rachel Heathers and Micah Litherland, and they are both program managers of infection prevention at Indiana University Health. Rachel and Micah are both CIC certified and have a combined experience of 15 years in infection prevention. Some of their areas of focus over the past years have been related to healthcare-acquired infection reduction, COVID-19 response, of course, and outreach communication among the infection prevention teams. Our moderators will be Ann Gazda, who is the clinical program leader for the U.S. region at Becton Dickinson, where she explores innovative ways to collaborate with hospital systems with the goal to drive down and sustain progress with healthcare-associated infections. Preceding this role, she served as National Manager of Clinical Operations for the Urology Critical Care Division at BD. Ann holds a bachelor's degree in nursing from St. Louis University and a Master of Education, Policy and Organizational Leadership from the University of Illinois. Autumn Langford serves as a Senior Adoption Manager for the BD HealthSite platform. She is a registered nurse with clinical experience focusing on critical care and emergency medicine. In addition, Autumn is a certified infection preventionist and worked at several facilities as an infection preventionist prior to joining the BD Advisors team 7 years ago. As a reminder to participants, again, you may submit your questions via the chat box during the discussion, and they will be addressed at the end of this session. Micah, over to you.
Hi, good afternoon. Thank you for having us. First things first, we wanted to talk to you just a little bit about IU Health and who we are. IU Health is the largest network of physicians in the state of Indiana. We've got 16 hospitals across Indiana, including academic health center. We have pediatric facilities, multiple acute care facilities, and critical access hospitals. We have over 30,000 employees within the system. We have a great partnership with the IU School of Medicine that obviously gives us multiple benefits to be able to provide the best, most tailored care for each patient's individual needs. You got the slide? Sorry. So digging in just a little bit further, we wanted to show you that the System Infection Prevention team has several members in it, but we also wanted to point out that each of our facilities do have at least one infection preventionist or IPs that are on site, and our team is in place to help to support those IPs. Our team consists of a Chief Quality Officer, Dr. Cesana, our Medical Director of Infection Prevention, Dr. Webb, our Executive Director, Lori Fish, Rachel and myself are program managers, as mentioned, and we've got Carla, who's our project manager, who keeps us all in line, makes sure we're running smoothly, keeps us going every day. Dr. Webb, Rachel, and myself have all recently joined the infection prevention system team just within the last year.
So again, thank you, ladies, for your time and your commitment to patient care. So Rachel, you've been in your role a little over a year now. And so you started this new role and you had a pandemic that hit, and then you were approached with this project opportunity. So what intrigued you about this opportunity?
Well, Autumn, you're right. I was actually in orientation when COVID hit, but I am so fortunate to work for an organization that is always chasing zero harm events. IU Health is always looking for new ways of keeping our patients safe. This project outline was developed before COVID-19 hit the shores of the United States. We were looking for ways to harness technology to lower our HAIs in a targeted manner. In the past, IU Health has strived to decrease the impact of HAI. However, sustainment of reductions has not always been realized. We want to partner with fresh eyes to the IU Health processes.
And so, as Micah mentioned, there were several new team members. Specifically, she is new to this IU Health team from the corporate level. So what was the determining factor that you need additional resources at the corporate level?
Well, this actually occurred about a week or maybe even 2 weeks into the pandemic. I work for an amazing leader, Lori Fish, that was in the trenches with me. We had so much work to do that we were at Incident Command Center for such long hours. Lori recognized the need and worked to get another program manager position. The addition of the new position happened over a few days compared to months. When we received notification, Lori, Carla, and myself put our heads together to review recently transitioned infection preventionists, or IPs, that we could recruit from. We did not want to pull from the talent that our 16 hospitals had because we needed those infection preventionists to be boots on the ground in their facilities. We all three looked at each other and we said without hesitation, Micah.
Micah, you're so lucky. So as you two are working together to lead this charge, what are some key things that you attribute to your success to working together?
Rachel and I have really become great BFFs on Teams. Teams is the Microsoft platform that IU Health uses for a good majority of its virtual meetings and collaborations. So when we had tasks that were assigned to us, we would set aside time, like each day we would load these documents and projects into Teams where we could both incorporate changes at the same time, and then we could move through them really quickly.
And I'm going to tag on to that. Together, Micah and I, we are speedy. We're both trained infection preventionists. It's so nice because we have a consult in the room with us, at least through the virtual platform.
Very good. So Rachel, thank you all for sharing the org chart. So it really, I think, helps everybody get to know you a little bit and how things run at IU. Question, with yourself being involved early on in this project, and of course adding Micah later on, you're focusing now on CAUTI. How did you decide that CAUTI was going to be the HAI that you went after first? And then, how did you support that? And was CAUTI always the place that you wanted to start?
So funny thing, CAUTI wasn't where we wanted to start. Like all things 2020, this too changed. At the program's inception, we were going to start with bloodstream infections, or BSI. However, since the original discussions, a half a year had passed and the focus was now on COVID. Fully catheters were being left in longer to help reduce time in the patient's rooms. Under the direction of Lori, we decided to relook at the data. We then partnered with our local IPs and their harm teams, and they reviewed central line and Foley catheter infection data. With them, it was determined unanimously at the local level that our focus should be shifted to catheter-associated urinary tract infections, or CAUTI, for harm reduction. Additionally, IU Health is a very values-based organization. We were presented with an opportunity to grow in ways we never could have dreamed of in the past. We were amid a pandemic. like the rest of the nation. And we went back to our IU Health values. It was imperative to include the frontline staff and always ensure that the program is patient-centric and in alignment with our value of purpose and team. We demonstrated excellence and compassion by keeping in mind the exhaustion from the frontline staff with over 1,000 team members on quarantine at one point in time, while trying to create a program that had never been presented before at IU Health.
Well, it sounds like, number one, the infection prevention team is incredibly empathetic to everything that was going on at the front lines, while also bearing in mind that there might be patient harm occurring, and you needed to address it, and it was urgent. And then within all of that, you were able to quickly pivot from bloodstream infections over to catheter-associated urinary tract infections. And it sounds like it was just kind of the tip of the iceberg, right, with what you were seeing. So with all of that being said, how did you make this palatable? How did you drill down and, number one, after you selected CAUTI, how did you decide which sites you were going to hit to make sure that whatever interventions you brought forward could be represented at every other hospital within your system?
So I have to say that, as Micah highlighted earlier, IU Health has so many diverse types of facilities. We wanted to make sure that the project could be implemented at all 16 of our sites, not just one. And we also wanted to make sure that what we implemented was measurable and reproducible, so we could have the duplication of great patient outcomes. Of course, we went back to the data, and it was data-driven. And once we looked at the data, we decided that we needed an academic health center, an acute care site, which was Ball, IU Health Ball, and a critical access site, IU Health White. That way we would have the opportunity to test and spread across all the hospital types.
Thank you.
So ladies, in order to identify the opportunities that could potentially be there, you obviously conducted a very multifaceted assessment. So, and on top of this, Indiana was seeing some of the highest numbers of COVID cases in the country at this time. So Micah, I can assume that this was a large undertaking to do this assessment. So did you do assessments at each of the individual sites that you had selected?
The assessment was conducted at each of the 3 pilot locations that Rachel talked about. We used a heat map data source that actually shows us what day of the week most infections are likely to occur within those individual facilities. And by using that information, we chose a specific day for the team to be on site for the assessment. And during this week, we were able to complete about 150 catheter observations.
That is amazing. So how long did it take you to do the assessments at each site? And how did you determine which resources at those sites that you would need? Because I'm assuming that you can't do this all by yourself.
No, we might be miracle workers, but we're not that great. The site assessment actually occurred over a period of 3 days that we were actually on site. It was Tuesday, Wednesday, and Thursday. And then we had an additional training session on Monday. We did rely heavily on the BD team to shape the assessment. And then we relied on the IU Health Boots on the Ground team, comprised of infection preventionists and clinical nurse specialists, or CNS, to determine the units and carry the assessment out with our BD partners. We were using assessment tools and criteria that had not been used in the past by IU Health or BD. So this meant we had to train our observers during a pandemic. So once again, we harnessed technology to train those who assisted. We kicked things off with a virtual meeting on Monday, and we offered several training sessions throughout the day to be flexible and allow all participants to attend. None of us were in the same building, the same room, or even in contact with each other except by virtual means until the next day. Everything was virtual. The 4 primary leads, just as a fun fact on this project, have never actually been in the same room.
So to answer the second half of that question, in the surge of COVID, we had tons of resources that we could not put in the hospitals due to the additional need for PPE, the additional burden that it would put on our already overwhelmed healthcare team. We're surging, we're caring for patients in non-traditional spaces, as well as trying to keep as many people out of the facilities as possible to minimize COVID spread. It was a balancing act. We put our minds together to figure out a way that we could conduct an assessment while keeping all of those things in mind. And we went to the concept of having a bedside team looking at the patients on site, and then we coordinated with individuals off site to take care of chart abstraction and actually leading the project.
That sounds like quite a balancing act. So you can see you have outlined for us a lot of the data points that you looked at in the evaluation. So why was it so important to look at each of these areas?
Well, when you think of CAUTI, you think of maintenance bundle ideas, such as bag off the ground, securement device in place, and no dependent loops. But what we discovered is CAUTI is so much larger. What we were really looking at was all aspects of urinary management. We needed to go beyond the catheter. We wanted to take a comprehensive approach to all urinary output management. We reviewed from the time the patient entered the healthcare system to the time of discharge. We reviewed items like specimen collection, in and out cathing, insertion techniques, and of course, charting.
We were able to complete all of this like within a 3-day time frame, and we finished the assessment on Thursday, thankfully, because Indiana went on the do not travel list for several states on Friday, so BD was out.
Yes, we were skedaddling on our merry way out of Indianapolis. So this is remarkable, and it sounds like you really conducted this comprehensive assessment with a lot of data points. Just looking at that graphic on the slide before, there were so many categories and things to look at just within the urine. I think similar to my prior question about knowing where to start with the HAI and then knowing which facilities to go to, how did you continue to stay in scope with all of those data points? How did you know where to start as far as what to address and what you could improve and act on?
So we simply used an effort impact grid. During the assessment, we had daily virtual touch points with all of our people who were on the ground doing the observations, just to get a feel for what was going on in the facilities. Once we were done with the assessment for that week, we took a moment to breathe and gathered our frontline team members the next week to ask them where they felt like all the opportunities were. Once we identified all of those, we created this effort impact grid to try and capture where our focus should lie with the least amount of effort to begin. So you can see on the screen the 5 areas with the greatest room for improvement were urine sample collection with order stewardship, urinary management or alternatives to indwelling catheters, catheter insertion, appropriate indications for catheter placement, and adoption of the catheter removal protocol by nurses. And based on where we put these data points on the effort impact grid, we realized that we needed to start on urine sample collection. It's got the highest impact, high impact, but would take less effort than some of the other interventions that we're going to have to look at. It was crucial to gain the frontline team feedback because this is who the changes are going to be affecting. We had to make sure that we gave them a say in their work, and we had to find out what their opinions were on all of this stuff. And it was really interesting because when we actually collected all the final data and put it together, the things that they had pointed out in the assessment that they thought were opportunities did align with what our final data was showing.
And Micah, I just want to tag in here. Our initial impression was wow, we had a lot of opportunities that we hadn't realized before. It felt like the sky was falling. After the official data was reviewed, it was shared with our leadership, including this grid. And Micah mentioned it was clear our initial focus should be urine sample collection.
So just to take a tiny moment to brag on you, Rachel and Micah, from an outside looking in, and the type of leadership that the two of you displayed when working through all of this detail. And you know, the effort to impact grid may seem like something very simple, and in fact, it was very simple. You know, it's an X and Y axis with some boxes, but what you two were able to do in a display of empathy and in a display of excellent teamwork and wonderful change management processes was that you involved the working team from each one of those sites in the process, right? So you were collectively, virtually dragging and dropping boxes around on this grid to determine together, hey, how do we attack this issue? And it happened so quickly. Everyone, just because you had involved everyone in the process and you'd been so highly communicative along the way on a daily basis throughout that assessment, the answers were so clear. So I'll keep going here and ask another question. Again, to toot your horns, right? Infection prevention is everywhere, right? You guys weigh in on not just how to prevent bugs from spreading, how to prevent infections. I mean, you talk through things like the architecture and the layout of facilities. Your reach is so far. Within this program alone, thinking through all of the reaches, right? There were products that needed to be considered, processes, policies, procedures. You needed to connect with people from the highest level at IU Health in administration to products committee, value analysis team. How on earth in a virtual environment were you able to pull everybody together and get this to happen?
But Anne, I don't know what you're asking. We didn't need to talk to anyone. No, seriously, going back to values, this is where we really incorporated team. We took a step back and looked at the various parts and components of what we needed to utilize or change. We realized quickly that we were going to need input from lots of people, not just the bedside team members. We knew our lab partners were wanting to have input on how they receive the specimens. We knew we were going to need people from supply chain to help us understand what current state is and what future state could be, and to explore other options that would drive forcing functions to create that change we needed. We needed educators and doctors. Again, using data we obtained from the assessment, we were able to then go to leadership and ask for help from each identified discipline.
And since we have established that infection prevention really is a team sport, as we have talked before, you have your players at these individual facilities that they're battling a pandemic. You're taking care of patients in non-traditional areas. They have their daily whirlwind that they are dealing with. So how, keeping that in mind, how were you all able to go in and gain support and resources in determining their capacity to participate and help and implement this program?
So what you're asking is, how can we get people to do more with less resources, which is the $1 million question in healthcare. How are we going to do this? So we came up with the idea to send a survey monkey to assess the ability and any potential barriers that staff may identify. And based on the feedback that we noted, individuals were not going to have the capacity to assist with content creation. They just did not have time. However, they did let us know that they could still provide feedback on anything that we wanted to share. So in addition to individual capacity, we surveyed potential barriers to learning. We got several responses, and no surprise, the main barrier for learning was the COVID pandemic. So our smaller core team of 4 ran with this, and we just started creating educational content. However, we do know that education is a weak intervention, so we knew we needed to also ensure that forcing functions were in place. Some of the highlights from what we discovered led us to create some more lighthearted content in small bites. And after we completed all of this material, we had educators, infection preventionists, CNSs from around the system do a thorough content review and give us their thoughts and feedback on what they'd like to see.
And as we all know, change is always hard. When we're all in our routine and we're getting from point A to point B and someone wants to come and move my cheese, sometimes that's met with resistance. And so what challenges have you met and overcome, especially with working with so many different teams and also remotely? And do you feel that it's been a benefit or a challenge, an additional challenge to be working remotely?
Well, I'm just going to start by saying I've not been in the same room with Micah for at least 3 years.
Yeah, I don't know where my boss's office is. I don't know where my office is. I don't know if I have an office. I have never stepped foot in the building since I have taken this position.
But honestly, though, working virtually has allowed us to schedule online meetings and get people together who traditionally would have been traveling to another site for a meeting and would have taken a lot of time out of their day-to-day work. That's actually been an unseen benefit of COVID. Micah and I were further prepared for this by attending change management training. IU Health uses the ProSci ADCAR model. This model looks individually at awareness, desire, knowledge, ability, and reinforcement. Right away, we knew that awareness, ability, and reinforcement were going to be where we needed to focus, especially in a time where the last thing staff wants to hear is that they need to change the way they're doing something. The environment for education isn't exactly optimal right now, so we have to get pretty creative to make the program eye-catching and entertaining instead of instructional, and do it in small pieces that would be informative but not overwhelming.
So, ladies, with so many moving parts and departments involved, was there a challenge for you to know who to contact? How did you navigate that process? And also, obviously, those departments and those resources have competing priorities and they have their goals. So how did you all work together? How did you navigate those waters?
So we do have a huge advantage due to our position in the organization. By the way, Micah, when you need a tour, our office is next to the CNOs and have access to the decision makers in the leadership. I'll show you when you can come back to the office. But all our proposed interventions were presented with data in an SBAR format. Using this, we were able to show them what and who we needed and why. And they were more than happy to give us these resources. Our leaders showed that they supported what we were doing and validated the importance of the project. Our executive leadership team asked us to focus on COVID and harm reduction. This was a great model of leading by example and helped everyone else to understand that harm reduction was a priority and was the best thing to do for our patients. We also realized we had to prioritize our own projects. We had to put several things on hold to be available for this project and to allow us to finish it on a very tight timeline.
So as we discussed, and you guys alluded to that with the different size facilities, there was a need for standardization. So when you looked at the assessment and you found that there were some opportunities, what were those opportunities? Did you need to standardize policies, procedures? Did you find anything, any specific opportunities that you guys could address?
That's a really big question. All of that, yes. During the assessment, we noted there were tons of different ways that people were collecting urine samples, from the products to the processes. There were tons of knowledge gaps. So immediately we knew that we had to standardize to one specific product and teach to the most evidence-based process and really stick to that. IU Health follows Lippincott nursing procedures for all of our nursing practices. So we realized their guidelines for specimen collection from a Foley catheter were not up to date with the most current recommendations. So we put together an SBAR. For those of you who aren't familiar with that, an SBAR is a form that outlines the situation, background, assessment, and recommendation. We've done a lot of SBARs. So we sent that to Lippincott to demonstrate what we had found with a recommendation to update their manual. And our recommendations pointed out that using a lure lock access device to obtain the sample from the specimen port should be the preferred method, as well as the use of a preservative lab tube for any cultures. And they agreed and made the updates to that section in Lippincott as of Friday the 19th, actually. To date, we have completed the education series surrounding specimen collection, and catheter insertion is super close to being done. Next month, we're going to be looking closely at urinary management and drilling down on ways that we can avoid catheter use altogether. Then we are going to start on bloodstream infections.
So what I heard you say is you are an expert at SBARs, and and you still are working and having lots to do. So I hear job security as well. So when implementing this new process, obviously you all had mentioned that you were doing education, you were doing small bites. What did it look like to prioritize? Because as you said, there's lots of opportunities. And how did you work with the individual facilities to implement those changes and those opportunities?
So I'm just going to have to be honest, we're not quite there yet. I mean, we're still in the implementation phase. Our primary role was to create the education and ensure all supplies or forcing functions are in place for the go live. The individual facilities have taken on the responsibility for how they're implementing this. The reason is because not every facility will have the same top priority or be able to accept new information due to COVID. So we needed to make sure we had something that could be different time implemented. Going back to the other part of the question, the first and most important thing for us was to identify ways we could make this accessible to the educators, managers, and the bedside. We needed a brand so the staff would realize all these different posters and things they were seeing went together. So this created P-Man, as we affectionately call him, or You're in the Know. In addition, we created a digital magazine and videos that have all the pieces at the fingertips of those who needed it. We updated processes, as Micah mentioned, in Lippincott to reflect the best evidence, not only for IU Health, but the country, if not the world, so that what we had in Lippincott matched the processes we had in place at the bedside and what we were teaching the staff. So there wasn't variation. And then we also worked with the CNS team to continue to collaborate within the sites to prepare them for this education and what was coming.
So Rachel and Micah, it sounds like, and it looks like you employed all kinds of different methods and modes to provide education or training for the staff. How's it going?
It's not been easy. We had a lot of things that we needed to address, and we needed to address them quickly. So one of the first things we did was we set it up off-site to take the effort off of people's plates and make it so that the bedside staff did not even have to think about this. Number 2, we made it fun. Number 3, we made it short and simple. And then number 4, catch them when you can have a moment of their undivided attention. And the place we knew we could have 30 seconds of their time is when they were in the bathroom. There's no better place to talk about pee, and we all know where we do our best learning in healthcare. So one of the examples of what we created are the posters you see here. Some of the fun titles for these include Time Counts, that is education on what happens to a urine sample if you let it sit too long. Good to the Last Drop is for the urine collection tube volume to make sure they're filling them correctly. Go with the flow, we want to make sure that they're filling those tubes in the order in which they should be collected. So we really did just focus on the largest opportunities to try and remember that we are keeping this as a target focus based on the biggest gaps that we saw during the assessment.
I mean, who wouldn't want to look at a poster that's got a pea man on it? You know, it's very, very eye-catching, and he's kind of cute. So you mentioned, I asked how it's going. You mentioned that you're still in the implementation process and you're working on the urinary management portion of the project. Another $1 million question. I don't know how many millions of dollars we've amassed at this point in the conversation, but how are you keeping track of your progress and measuring outcomes?
So we have a few ways that we're doing that. We have dashboards that are currently being created that will be able to track and identify infection quality markers in near real time so that we can get the bedside that real time data and not have to have them wait or look retrospectively. We're also working on a few other innovative ways. We've created QR codes that are placed on the education that we have for staff that's tied to a Survey Monkey. This allows the staff to scan that QR code and give us feedback regarding the education and evaluate the program in real time. We have the ability to track down to what unit level and shift so that we can get back with that individual or let their education team know about questions that are occurring on their units. Before and after the intervention, we actually have tracking from the National Health and Safety Network, which I'm sure a lot of you are familiar with, that we will follow the defined CAUTIs before and after implementation. We're also following our device utilization rates. In addition, we're going to be completing another product assessment to compare it to the baseline, potentially around April of 2021. I also want to say, as an infection preventionist, one infection is too many. We are always chasing zero. And when we get to a sustained zero, we keep continuing to look for more opportunities. After all, we're talking about patient safety.
And thank you. As a fellow infection preventionist, I concur. So as we're getting towards the end of our time together, what advice would you give to other IPs that are listening? Because, this is a very large task, and they may be in a smaller critical access facility or an acute care facility and maybe saying, hey, I can't do this. I've got the pandemic going on. I've got, the daily whirlwind. How do I manage this? What is my first step? What advice would you give?
I would say the first step to that would be know your data. Data speaks. Use your data to speak to your senior leaders and display it in a way that makes it easy to understand. Make sure that you are able to compare yourself to like facilities so that you will stand out in issues where maybe you are doing well or not doing so well. This is really what is going to help you gain the support that you need to move forward with anything that you want to do. Know your resources. Keep everything patient-centered. be empathetic to the team at the endpoint. Anything that you do is going to ultimately affect them and their workflow. So you want to make sure that you keep those people in mind for sure. Take it one bite at a time and always be creative.
Well, thank you, ladies, for your time. I appreciate your dedication to your patients and all of the things that you guys have. I can't wait to see the results and the data that comes from this. So at this time, I'm going to turn it over to Dr. Calvin Yu to present any questions that may have been put into the chat boxes.
Thank you, Autumn. And I also want to echo our thanks to both Micah and Rachel. You may be aware that Johns Hopkins published a paper recently looking at COVID patients in their 5 affiliated hospitals. And they also outlined of the other non-COVID infections in their COVID patients, UTIs was the top. So congratulations to IU Health for recognizing that well before that paper was published. We appreciate your clinical and operational insights. We do have some time for some questions. One is, this is out of Writers Health. What are the steps for the nursing Foley removal protocol that you're following? Can shed some light on that.
So I'll go ahead and take that one. Our nursing Foley removal protocol is really based off of the CDC's indications for Foley catheters. So we have a protocol in place that allows nurses to remove catheters for patients who are not urology patients, who haven't had a huge abdominal surgery. So if you've got a patient who's just a couple days out of surgery for maybe they had a gallbladder or something like that and had issues urinating and had a catheter placed, our nursing urinary protocol allows them to remove that Foley catheter without a physician's order. We actually have to have a physician's order to keep catheters in for the patients who don't meet the criteria to have one, such as 24 or 48 hours after surgery or end of life, things like that.
That is nice. And you're referring to conditional orders that are pre-vetted and enable the nurse to act in lieu of a recent order, correct?
Yeah, absolutely.
Excellent.
All our protocols are vetted through our medical team.
I'm sure that's appreciated during surge capacity times. There's another question, looks like it might be from an administrator. How will you measure the success of your program?
So I can take that one, Micah. Thank you for getting the last question. So the measure of success through our program is using those elements. We want to make sure that ultimately we're having less infections. We want to make sure that our CAUTI number is going down. We also want to see for us looking at like urine specimen collection, is our contamination rates of urine decreasing? Ultimately, less harm happening to patients.
Excellent. And this seems like a sort of natural follow-up. How do you think this project will impact future change initiatives at IU Health? Any pull-through learnings that you might take with you, as one of the few positives of having a worldwide pandemic?
So I can start, and Micah, you can tag on. We're actually moving to the next project already. As you've seen, we're getting ready to start BSI. I think the biggest thing that we took from this is we do not need to be afraid to reassess and change. You have to have a fluid program and know when to pivot or keep your head down and persevere. We had so many false starts with this program at first because of the pandemic. We had to keep having the courage to try. And I think that that is one thing that we need to take forward to other projects.
Excellent. And Micah, anything else to add to that?
I would just say that the way that we've kind of implemented this project and set the stage for it helps us to set up future projects and know the avenues that we need to go and, almost a protocol for itself. And we know we need to do this and this and this first because we've learned very carefully and very quickly the proper avenues to go through. So I think that that just helps to set us up to move through projects a little bit smoother in the future.
Yeah, establishing institutional operational memory, if you will, I think will stand you in good stead. So thank you for sharing those insights. One last question from the audience. What ways have you had to modify your approach as you have progressed throughout this program? And then the caveat is, have you had to change or alter the initial scope? I think you answered part of that, but maybe this person wanted just a little bit more information.
Sure. So I can start, and I would say the way that we initially set up this program was we had everybody in the room that we thought would be involved. We had this huge kickoff meeting, all disciplines there, and then all of a sudden, boom, nobody had time. We were surging. There was over 1,000 staff out on quarantine. Numbers were higher than we've ever seen before in the hospitals. So we had to pivot. And when we pivoted, we said, okay, you guys, patient care is number one. You focus on patient care. We're going to focus on this project. And we started with our little core group of 4 and came up with new and innovative ways to be able to get the information out there so that people could vet with us without using a huge amount of their time, because their time was needed at the bedside.
Great. Well, you know, that really sums up, I think, one of the pull-throughs in this entire webinar, which is that infection prevention programs, like stewardship programs, they're not just policing forces. If you put patient safety first, like you articulated, it becomes a cross-functional team with, you know, a lot more to add than just, hey, wash your hands. So thank you so much for sharing your insights. I do want to say that this is the third of 4 complete webinars that we are focusing on today on the theme of infection prevention and pharmacy, the road to integrated stewardship during a pandemic. And if you want to visit our last webinar, starting in about 10 minutes, please visit the link in the chat below to register and participate. As a final reminder, the spring event, which is a virtual customer series called All Together Now, Driving Patient-Centered Care Through Connectivity, will be in May, and we'll be addressing specifically specialized reports to specialized analytics. So please mark your calendars and watch for further information. Ladies, this was an excellent information on clinical, operational, administrative pain points. I want to congratulate IU Health again for identifying an HAI before that publication came out from Johns Hopkins. Not bad company, if I might say so myself. And wish you all a great rest of the day. And thank you so much for sharing your insights during the pandemic.